Prevalence of delirium in hospitalized older adults. Delirium is an acute and fluctuating disorder of consciousness and cognition and is considered to be the most frequent neurobehavioral disorder in hospitalized older patients. Delirium affects 56% to 72% of ICU inpatients. Delirium also occurs in 14% to 56% of hospitalized older adults. It can also occur in 7% to 17% of patients in hospital emergency departments. And in a study of 10,014 admissions in January 2012 through June 2013, delirium occurs in 24.6% of patients 65 years and older. And another study in 2012, 29% to 31% of hospitalized older patients without delirium on admission develop delirium during their hospitalization. Delirium affects between 11% to 51% post-op older patients. It also affects 21% of hospitalized older patients 6 months after discharge. Delirium is linked to high mortality rates up to 1 year post-discharge. The cost of delirium is between $16,303 to $64,421 per person. An estimated annual delirium cost is $152 billion. The manifestations of delirium include increased morbidity and mortality, increased hospital cost, as we just discussed, risk of dementia and institutionalization after discharge, increased risk of infections, and longer hospital stays. Causes of delirium in hospitalized older adults. With lack of adequate research on delirium, the exact mechanism of cause within the brain is unknown, but there is speculation that it is related to abnormalities of brain neurotransmitters. Some causes of delirium are due to the direct physiological consequence of a medical condition, intoxication, withdrawal, toxin, or multiple etiologies. Certain medications can play a role in an elderly person's cognition given the right environment and susceptibility. Here are a list of some causes: old age, male gender, underlying cognitive impairment, infection, major surgical procedures, somatic pain, treatment environments, fever, hypoxia, hypoglycemia, electrolyte imbalance, use of drugs such as benzos, narcotics, other medications, central nervous system disorders such as TBI, epilepsy, a history of delirium or stroke, metabolic disorders such as encephalopathy, and general medical conditions such as cardiovascular, renal, and hepatic diseases.
Diagnosing of hospital delirium. Nurses and doctors can use a confusion assessment method called CAM. A CAM assessment is a standardized evidence-based tool that enables a non-psychiatrical trained clinician to identify and recognize delirium quickly and accurately in both clinical and research settings. A CAM includes 4 features found to have the greatest ability to distinguish delirium from other types of cognitive impairment, which includes your Alzheimer's, your dementia, because both of these sometimes get confused with each other if a CAM assessment is not completed at the beginning of a hospital stay. This is the way the CAM assessment is performed. Nurses can keep their eyes on their patients to make sure that there are no changes. The alteration in mental status or the fluctuating course. If this is a yes, then you go down to the second feature. If no, then there's no delirium. You tell the patient to squeeze your hand when they hear the letter A, and you spell out Saveheart, SAVEAHAART, and you can use picture cards. If there's 0 to 2 arrows there is no delirium. If there's more than 2 errors, then you go down. Feature 3, alter level of consciousness. No or yes. If it's yes, then you have delirium. If it's no, then you go down to disorganized thoughts. And this is when you ask questions like, will the stone float? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Can you use a hammer to pound a nail? If the patient can answer the questions with 0 to 1 errors, there's no delirium. More than 1 errors, they say it's delirium. There's also a model called Brief Confusion Assessment Model, a BCAM. So providers can use a BCAM as a quick assessment tool because it takes 2 minutes or less to do. It's accurate in identifying delirium, but it's not the best option because it's been known to miss 3 out of 10 patients. This type of assessment is great for the ED, or if a nurse is thinking that the patient's got hospital delirium, this is when they can use this type of assessment before calling a provider in to do a large CAM assessment that takes 10 to 15 minutes.
Delirium interventions. The prevention of delirium has shown to have better patient outcomes than the treatment and management of onset delirium. Given that delirium has a multifactorial predisposing etiology, the interventions must have a multi-component approach to reduce the vulnerability in older adults. Evidence-based research and practice has shown that multi-component interventions that include mobilization, avoiding physical restraints, reorientation that is a part of care, using devices that support vision and hearing, a review of psychoactive medications, infection prevention, and ensuring sleep, adequate fluids, nutrition, oxidation, and pain relief are effective in preventing delirium. Empowering staff with education, assessment of risk factors, and interventions to reduce risk factors are supported by evidence to prevent delirium. There is no current evidence that supports the use of pharmacological interventions or treatment for delirium. In fact, it is encouraged to eliminate all unnecessary medications and limit psychoactive medications during delirium management. Management and treatment of delirium includes control of environmental factors that can aggravate or induce stress, such as artificial lights, noise, overstimulation, and multi-bed rooms. Facilitating sleep management. If possible, early mobilization, such as walking, range of motion exercises, and sitting up in bed. And providing patients with patience and compassionate care. Although pharmacological interventions are not encouraged or supported by evidence, haloperidol has been the most popular drug used for delirium as a last resort intervention. However, there is still limited and conflicted evidence of the efficacy, and it is recommended for short-term use only.
Although the exact mechanism of delirium in older hospitalized adults has not been identified, research and evidence-based practice have identified multiple causes that contribute to this neurological phenomenon. Methods, such as the confusion assessment method and brief confusion model, are both options nurses can use to quickly identify delirium in the hospital setting, allowing for prompt intervention. While there are defined non-pharmacologic evidence-based treatments, prevention of hospital-acquired delirium is the ideal intervention for best patient outcomes. By identifying those older adults at greatest risk for acquiring delirium, prevalence will be decreased as well as morbidity and mortality.